Thank you. Welcome, everyone. Thanks for joining Journal Club today. I'm Sing Pallett, the president of CMDA, and today our host will be Dr. Leah Ginsberg, nurse practitioner, who is a CMDA board member. Hey, Leah.
Hi. Hi, everyone. Thanks for joining today. And we have a really important topic, C. diff. Dr. David Shepard is going to be presenting. He's an internal medicine physician, as most of you know, is also on our CMDA board and a multi-facility medical director in Colorado Springs. So without further ado, feel free, Dave, and I'll just keep looking at the chat and whatnot for you.
All right, we're ready to get started. Let me see if I can share. You guys seeing that?
Yes.
Yes, no? Okay,
Yeah.
excellent. Okay, so yeah, I'm Dave Shepard. I'm going to give us an update on C. diff, on the treatment and diagnosis. First update is going to be that they changed the name. It's no longer Clostridium. It's Clostridioides difficile. I'm not sure when that happened. I missed that memo, but they're always changing the name of these organisms. I'm going to start with some just miscellaneous facts that I thought were interesting. Antibiotic use, as it seems like antibiotic use has increased the risk of colon cancer, both benign and malignant colorectal tumors. I think primarily colon cancers, though. So something we're doing with the antibiotics is altering the microbiome, and because of that, we're seeing an increased risk for colon cancer, and probably this is associated with the increased risk among a younger population, and that may be why we are now recommending screening at a younger population. So antibiotic stewardship is important from this aspect as well. This second study I thought was pretty interesting. Receipt of antibiotics by prior bed occupants was associated with increased risk of C. diff infection. So if I get admitted to the hospital and I'm sick and I get antibiotics and I get well and I get discharged, the next person that lays in my hospital bed, or the one that I was in, is at increased risk for C. diff infection. I kind of find that scary. A couple of other facts: the emergence of fluoroquinolones and our continued use and probably overuse of fluoroquinolones is strongly correlated with the emergence of C. diff infections. Particularly, it seems to promote strains that are more virulent, make more toxin, and make more potent toxin. Again, antibiotic stewardship is important. There's about a 15% asymptomatic carriage rate of patients in long-term care who are carriers of toxigenic C. diff. And you'll see numbers anywhere from 10 to 50%, depending on location and the study type. The diagnosis of C. diff, anywhere from asymptomatic carriage, which we just talked about, and we probably see more than we recognize, to fulminant disease. Risk factors are age greater than 65, PPI use, maybe even H2 blocker use. Anything that seems to suppress stomach acid may increase your risk for C. diff. PPIs are certainly more potent at doing that than H2 blockers are, but there is some association with H2 blocker use and increased risk as well. Antibiotic exposure, particularly fluoroquinolones, and I think it's probably time to retire clindamycin as our classic board question for C. diff, and probably put in fluoroquinolones as the instigator of C. diff infections and disease. The highest risk is thought to be about 30 days after exposure, but some studies show months or years after exposure, you can still have risk of C. diff disease. IBD, cirrhosis, transplant, immunosuppression, enteral feeding, all are risk factors as well. And again, the carrier state, lots of studies showing different percentages. I just kind of hang my hat on the 10% carriage rate in long-term care, and I think that will serve the purpose for us. Any broad spectrum antibiotics are going to potentially increase your risk of C. diff. If you're using multiple agents, that broadens the spectrum. If the duration is longer, that's more antibiotic exposure. All of those things are going to increase the risk further. So we want to use as narrow a spectrum agent as we can for as short a duration as we can. For diagnosis of C. diff, we want to see 3 or more, at least 3 episodes of watery diarrhea in 24 hours, lower abdominal pain, cramping, fever, nausea, anorexia. This can look like a lot of diarrheal illnesses, right? I mean, that just described norovirus and probably food poisoning and all kinds of other things. You may see some mucus or occult blood with C. diff diarrhea. You probably will not see melena or hematochezia with C. diff. If you see that, you probably want to look for other causes, GI bleeds, or maybe a hemorrhagic E. coli or Shigella or something like that. Fulminant colitis is, I think of it as C. diff infection with sepsis, basically. Hypotension, multi-organ failure. You can see toxic megacolon, big distended abdomen, and the cutoff on X-ray for megacolon is a colon of greater than 7 centimeters. Recurrent C. diff is defined as resolution of C. diff infection with reappearance of symptoms within 2 weeks or 2 to 8 weeks. There's a 25% recurrence rate within 30 days. It is typically relapse. It is not typically a new infection with a new strain. And the lab findings, usually there's leukocytosis, again with severe disease, hypotension, acute renal failure with elevated creatinine, maybe an elevated CRP. That's pretty nonspecific. Leukocytosis is obviously present. Maybe leukopenia if they're immunosuppressed for some reason. And we'll talk a little bit about the testing specifically for C. diff, but you'll see a positive PCR test or GDH, whichever one you're using for your sensitive test, and you'll see a positive enzyme immunoassay for the toxin as well. And we want to remember that we only want to send liquid stool for C. diff testing. I included the Bristol stool chart there on the left. I use this as a tool to talk to nurses about what diarrhea actually looks like. I was always taught that true diarrhea will conform to the shape of the container in which you put it. And that's kind of my short education for nurses who, diarrhea, sometimes they call loose stools and all kinds of things diarrhea that really doesn't fit. Again, we want to test only symptomatic patients who have significant diarrhea, 3 or 4 stools in 24 hours. We need to remember that C. diff toxin degrades at room temperature in about 2 hours. So we want to either freeze the samples or put them at 4 degrees. We'll talk about the 3 tests that we can use for diagnosis. And toxigenic culture is still the gold standard, although it's labor intensive, it's slow. I'm not sure that it has much utility nowadays. If you remember, it's called difficile because it is so difficult to grow. I think that culture probably has not been used for quite some time now. We will use a 2-tiered approach for C. diff testing, a sensitive test combined with a specific test. And we'll talk more about those coming up here. The GDH test is for glutamate dehydrogenase, which is an enzyme produced by all C. diff. Also, I think it's part of our citric acid cycle, but we generally don't see it in our colon. So it's used for testing for C. diff. It's very sensitive, but it's poorly specific. And it's really been supplanted by PCR, I think. So we're just going to move on to the PCR test, which is highly sensitive, 93 to 100% sensitivity. It has a poor predictive value, mainly because it will detect colonized patients. It will detect C. diff that is viable, non-viable, toxin-producing, non-toxin-producing. Anything that has the C. diff TCD gene is going to light up on a PCR study. So you can have a decent false positive rate in colonized asymptomatic carriers. So that's why we take this sensitive test and combine it with a specific test to improve the test accuracy. And the enzyme immunoassays, it's primarily for toxin B. That's the more potent toxin. It's 99% specific. It is only about 75% sensitive. It takes about 100 picograms of toxin before the test will light up as positive. So it's not a good initial screen, but it's very specific and is a good confirmatory test after our initial testing. So just to recap that, we want to use a sensitive test such as the GDH or the PCR / nucleic acid amplification test, combined with a specific test, such as the toxin A or B immunoassay. There's different permutations of results here, right? Primarily, what we're interested in is that positive sensitive PCR test and the positive toxin test. That tells you that in the right clinical scenario, it could be a C. diff infection, and you probably want to start antibiotics for that. If the PCR test is positive, but the toxin is negative, then the person may just be colonized with a toxigenic C. diff. It may not be the cause of their diarrhea. So you probably need to investigate a little further and determine whether or not there's another cause for the diarrhea. And these are just from up to date. I stole them and put them in there for your reference. I also wanted to mention that fecal leukocyte testing is probably not a good way to test for C. diff. I don't see this done much anymore, but I did want to mention we probably should just let that go and stop doing it. There's no need to retest after treatment if symptoms resolve. If you see what you think is recurrent disease, you may want to retest. It can be difficult to interpret. Stool assays may be positive for up to 6 weeks after infection. And there's also post-infectious IBS that can look a lot like C. diff. So it's really hard to make that diagnosis for recurrent C. diff. Better part of valor most times is probably going to be to treat it as recurrent C. diff unless you can find a way to differentiate it. We don't want to forget the other causes of diarrhea. Antibiotics can cause diarrhea without causing a C. diff infection. Osmotic diarrhea usually stops if you hold PO intake for 24 hours or so. Other causes of infectious diarrhea we want to investigate. There are non-infectious causes: inflammatory bowel disease, celiac, ischemic colitis. All of those hopefully have some kind of a clinical indicator that you can use to differentiate. And C. diff treatment, of course, contact precautions, hand washing. Discontinue the antibiotic if you can. If you can't, you might try to switch to an antibiotic that is less prone to cause C. diff. And I've listed some of those on the side there. Tetracyclines, maybe doxycycline, tigecycline. I'm not sure chloramphenicol is used anymore ever, but it's on the list as well. As far as anti-motility agents, this is kind of controversial. I do use loperamide. I generally stay away from diphenoxylate atropine. I feel like diphenoxylate is just a little more potent. We were probably all taught that if you have an infectious diarrhea, you don't want to use an anti-motility agent. I think the thinking on that has changed a little bit. So I will use loperamide carefully and monitor carefully, just as symptomatic therapy to hopefully get them back to eating and drinking a little sooner. Recap: acute diarrhea greater than 3 liquid stools in 24 hours, positive C. diff specific labs, and no alternative explanation for the diarrhea. And we want to remember that severe CDI is characterized by significant leukocytosis along with renal failure, possibly even hypotension, megacolon. If that's the case, you might want to consider hospitalization for therapy. The antibiotics that we're going to use has changed a little bit over the years. Fidaxomicin is definitely the #1 choice now. Vancomycin is #2. Metronidazole is #3. Fidaxomicin is expensive, about $300 a pill from the resource I found. It has a lower recurrence rate. It targets C. diff better than vancomycin. No adjustment for CKD or hemodialysis, and it causes minimal alteration of the microbiome, which leads to less relapse. Vancomycin, on the other hand, is essentially a gut bomb. It kills most of the gut microbiome. Oddly enough, it is, as you know, a gram-positive specific antibiotic, but it seems to lead to alterations in the microbiome that causes loss of most of the gram-negative species as well. And metronidazole is our third choice. It has higher rates of treatment failure. It increases mortality in those that are over 65 years of age. It is off-label, actually doesn't have an FDA approval for C. diff. And it's primarily absorbed in the small intestine. So I'm not even sure how much of it gets to the colon to directly attack the C. diff. And recurrent C. diff, your first recurrence, if you treated with vancomycin, then try fidaxomicin. If you treated with fidaxomicin, then you may consider a tapered course of vancomycin. There's all kinds of tapering regimens out there. I just listed the first one I found. The second recurrence, this is where it kind of gets interesting. There are a couple of products now that you can try for second recurrence. In addition to your antibiotic, you're going to give the antibiotic course, and then 24 to 48 hours later, you might try a fecal microbiota product, such as Rebiota, I guess. It's I don't know how to say that. It's a rectal suspension made up of Bacteroides species. And you have to thaw it out in the refrigerator and give it within about 48 hours of your last dose of antibiotic. Another one is a capsule that is made of spores from the firmicutes. I guess it would be the phylum. It includes Bacteroides and Clostridium, a number of other species that are spore formers. It has about a 28% reduction in recurrence. By the way, fecal microbiota transplant is no longer on the table. I think you have to have an IND to do it, so it's actually not available for us anymore. If you have a third recurrence, I would probably get some help from infectious disease or GI at that point. You may be looking at a trial of suppressive vancomycin therapy, maybe long-term. For the treatment for fulminant C. diff, it's going to be vancomycin PO and metronidazole IV. You're trying to attack it from two different angles there. Some people would recommend a vancomycin enema if you feel like there's an ileus present. That's kind of controversial. You want to keep monitoring therapy, and if the patient gets better, you could stop the metronidazole. If there's no improvement, you may want to consider a surgical consult or possible surgical intervention. And in fulminant C. diff, you may want to consider checking a vancomycin level. Even though vancomycin typically isn't absorbed orally, if you have a big inflamed colon, you may see some absorption into the bloodstream. And in somebody with severe CKD, it could be significant. So you might want to monitor that. And these are a flow chart and a table, again, that I stole for your reference. Bezlotoxumab. This is unfortunately no longer available. It was a monoclonal antibody against toxin B, and it actually did show some decent efficacy. Merck stopped making it. They did not give an explanation for why they stopped making it. So I don't know what happened there. There are some newer antibodies under development, though. And probiotics. I looked quite a bit at this. It's probably time we just stop using probiotics until we iron out what species we should use and how to do it effectively. The ACG determined that there's insufficient evidence to recommend any probiotic for primary prevention or secondary prevention of CDI in most patients. But what could it hurt? You know, what's a probiotic hurt? Well, there have been case reports of bacteremia from probiotic bacteria in immunocompromised patients. And probiotics may delay the reconstitution of the normal gut flora, which is kind of what we're trying to do post-antibiotics. So it may actually prevent us from reconstituting what is a normal gut flora. There have been a lot of studies on probiotics, variable scientific rigor. The trial that I listed here, the Plecide trial, it was a randomized double-blind RCT. It showed no significant reduction of antibiotic-associated diarrhea or C. diff-associated diarrhea with use of probiotics. So it may be time to retire probiotics both for primary prevention, which is giving them with an antibiotic to prevent C. diff, and for secondary prevention, which would be giving them after C. diff to prevent recurrent C. diff. There is an investigational drug, VE303, which just finished a phase 2 trial. It is 8 strains of commensal Clostridia. I'm not exactly sure how you administer those. It's still in the study phase. It's going to begin a phase 3 study soon, so we may see that in the future. And this is just a list of C. diff pearls that I swiped from the podcast that kind of initiated my interest in doing this talk. It is, I don't know if any of you listen to the Curbsiders. I think they're pretty good, pretty entertaining. The podcast on C. diff has an infectious disease expert who does research in C. diff. She answers a lot of questions, and I found it very interesting. So you may want to give that a listen for more info. And my references are available. We'll put the slides up on the website too. I've got some supplementary stuff here if you're interested in it, but the American College of Gastroenterology also has a pretty good treatment outline for C. diff as well. And that's about all I have got.
Thank you. We do have one question from Dr. Reddy. Due to cost, we've not had much success in prescribing fidaxomicin. Are there any recommendations on how to improve the approval rate to utilize the first-line agent?
Yeah, I've had the same problem. No, I don't have any good advice. Does anybody else out there found a trick? Do we have any pharmacists on the line that might have a trick?
You might have to fail the cheaper therapy, right? Before they'll approve it.
I think so,
Mhm.
which is unfortunate because, fidaxomicin is definitely, from a science standpoint, the right drug to use.
I also have trouble with like med A stays. They might get started on it in the hospital, but the facility can't afford to take them on it. So they get
Yeah,
they go.
a 10-day course at $300 a pop. That's pretty significant expense when vancomycin's probably pennies compared to that.
Dr. Palat asks, is there consensus on using bulking agents, cholestyramine, during C. diff? Also, when do you stop contact isolation?
I have no idea about the bulking agents. I don't know that I've ever seen that. Does anybody else know?
I think you have to time it really specifically between your antibiotic dosing. I don't know if there is a pharmacist on. I know it better, but I know you have to be pretty specific if you do use it to prevent that because it won't be effective. I feel like.
So is the idea there like psyllium? It's kind of a prebiotic, and it might help restore microbiome.
Like just bulk the stool.
Okay, so it's just for bulking. Okay.
Yeah, like I don't know if that's any better than just trying to slow it down with loperamide or something.
Yeah, I unfortunately just don't know the answer to that. What was the second question?
When do you stop contact isolation?
Yeah, good question. I stop contact isolation when they stop having diarrhea and they, appear to be clinically better. That's usually a couple of days after the diarrhea. I'm not sure that I know the exact answer that the CDC wants to hear. Does anybody else have any other practice that they tend to use?
I think the standard is, I guess, to this is a contact isolation after 2 days of normal bowel movement. That's the last I know.
Yeah, that's pretty logical. I think that
On
makes sense.
treatment, but the symptoms have been resolved. I think it's
Okay. So there's no requirement for like a week after resolution or anything like that.
And Dr. S already said failed therapy with ID consult led to microbiota pills, but still no fidaxomicin.
Oh, wow. Yeah. I can't explain why insurance doesn't follow science, but it would seem like at that point you would want to use the fidaxomicin along with the microbiotic product.
I was going to ask you, you mentioned that metronidazole increases the mortality rate in patients greater than 65. I hadn't heard that specifically, so I was curious where you had found that.
Yeah, I could give you the reference. I didn't dive into that too much. I hadn't heard it either. And I hadn't even thought about where it's absorbed either. I don't know why it would increase mortality in those over 65. So I would have to look into it further. But
I'd be curious to know if it was a specific dose or length of treatment, or just using it at all.
Yeah, I don't know off the top of my head.
Hey, any more questions? Comments?
I think the only thing I would add to what we've been talking about is that I think it's facility directed or facility specific how many days we keep people on isolation, because it does cut into insurance approval of therapy days when they are limited on how much therapy they get within their room. So if they have not had a specifically watery stool, like it might be loose, but if they're having less than 2 loose bowel movements and they're not completely watery on their oral vancomycin, they will allow them to go last to the therapy gym after all the residents have completed their therapies. And if they're less than 2 a day and, semi-formed or something like that, they will allow them to do therapies so that they can continue to have skilled days.
Yeah.
Is it okay if I weigh in? Don Murphy here. David, excellent summary. All right. 2 things. One is just follow the news stories on RFK Jr., the CDC. God knows what's going to come out of all this mess. All right. I mean, it's remarkable. And number 2, you had asked, you don't understand why insurance won't cover it. Have you ever heard of this thing called profit motive in medicine?
Yeah, I think so.
Yeah. Well, that explains it. Okay.
Yeah, it's unfortunate, isn't it?
It is.
Yeah. Okay. Anyone else? Any other comments? Any updates? Anything like that?
Thanks for that wonderful summary and presentation, David.
Thank you. You're welcome.
All right. Everyone have a great rest of your day. We'll see you soon.
Thank you.
And thank you, guys.
Thanks. That was great. Thank you.
Thank you. Take care, everyone.
Guys.
Mhm.
Appreciate it, David. Thanks for putting that all together for us. Oh, you're on mute, but that's okay. The meeting's over.
Did I talk too fast?
Not at all.
So,
I feel like I'm just rambling, but okay.
No, it was perfect.
All right, good.
you pretty well.
All right, guys. Have a good weekend.
Thanks, you too.
See you. Bye-bye.
Bye.